And today I will be talking about the development of our new relaxin-2 for heart failure with ejection fraction. So why HFpEF? What's the rationale behind all this? You certainly know that 50% and rising of patients with chronic heart failure and heart failure with preserved ejection fraction, HFpEF. So in Germany, we are talking about 750,000 patients. In the EU, almost 4 million. In the US, almost 3 million patients. And I think it's safe to say that due to the ongoing obesity and diabetes pandemic in the Middle East and South Asia, especially, there will be many more patients in the nearest future. And to me, this is still the biggest unanswered question in contemporary biology, to find the mortality-lowering drug for HFpEF. So, heart failure in general is the most common cause of hospital admission. It's among the 3 most common causes of death in almost all industrialized countries. So it's a huge socio-economic problem. And the HFpEF prognosis is comparable to heart failure with reduced ejection fraction. So we are talking 50% death over 5 years. So it's meanwhile deadlier than most cancers. But in striking contrast to HFpEF, there is still no mortality-lowering pharmacological treatment for HFpEF. There has been a market approval for SGLT2 inhibitors recently, but those have only been shown to lower hospitalization for heart failure. They left mortality totally untouched. So still a lot of space to improve treatment here. And to me, HFpEF has always been a job description for relaxin-2. This is a nice picture here of Chilpe and Paulus of 2013 showing the pathophysiology of HFpEF. So in HFpEF, the vessels and the heart kind of fall victim to a whole body metabolic inflammation that is driven by the usual suspects, so our lifestyle risk factors, hypertension, diabetes, etc., and simply age. And this drives an inflammation, and this leads to generalized vascular stiffening or endothelial dysfunction, as you like, and of course, diastolic dysfunction. And actually, I can safely say that relaxin beneficially impacts on almost every step of this pathophysiology here. So it's a vasodilator, it's a functional antagonist to endothelin-1, it's an anti-diabetic, we have a patent on that. It's a strong anti-inflammatory agent, so the glucocorticoid receptor surprisingly plays a role in that. More on it in a minute. It's a very strong antioxidant. It's the most potent antifibrotic we know, even preclinically, I would say. It has strong antiarrhythmic effects, more per minute, and regarding endothelial function and diastolic function, it improves the hypophosphorylation of titin, which is a reason for this diastolic dysfunction, and it preserves this nitric oxide cyclic GMP protein to MSG axis, which is down in heart failure. So some words on the basics of relaxin-2. It's a peptide from the insulin superfamily. When looking at this picture, you might even mistake it for insulin. A-chain, B-chain, disulfide bridge. It's like insulin, but it's different from it, and it has a whole bunch of own effects. It has been discovered as pregnancy hormone. So in human pregnancy, in the first trimester, relaxin is the hormone that adapts maternal circulation to the need of pregnancy. And we use part of these effects now for heart failure, for old hearts, so to say. When I say relaxin, I mean relaxin-2. That's the major circulating form. Relaxin-3 is a neuropeptide, a totally different breed. And regarding relaxin-1, it's not even clear if it is expressed as a peptide in humans. So it's just relaxin-2 I'm talking about. The cognate receptor is the relaxin family peptide receptor 1, a G protein coupled receptor. It's kind of personal history. I stumbled across relaxin in the late 90s. We were doing research on heart failure. We were into endothelin-1, green medallion, this hot topic at that time. And yeah, we just measured relaxin levels. And this is how it began, and it has captivated and fascinated me ever since. So we were the first to describe that endogenous human relaxin rises in human heart failure and plays a compensatory role, one could say, like the natriuretic peptides, for instance. We elucidated a couple of basic mechanisms, among them this glucocorticoid receptor activation, and we undertook the first clinical trial in heart failure patients, phase 1b, back in the early 2000s. And we did a lot of work on relaxin pharmacology. And relaxin signaling is most pleiotropic and most complex. So why is that so? This receptor is a G protein coupled receptor of its own class, because I think it's the most complex GPCR we know of today, or at least among the most complex. Why is that? There is relaxin binding to this receptor at 3 different sites: at the transmembrane domain, at the linker, at the leucine-rich repeats. And every binding step causes subtle conformation changes that finally lead to this LDL module here to bind to the transmembrane domain and kind of switch on signal. So it's a multi-step, very complex process. And this is why even big searches in NIH, high throughput libraries or big pharma have so far not come up with a real non-peptidogenic agonist, the real agonist. The only hit in the NIH search was what we call a biased agonist. It is something that allosterically binds, so at a different site from relaxin at the receptor, and does some of the relaxin effects, but not all. It's just different. It's a biased agonist. Okay. More to it, there is no such thing like canonical signaling for relaxin. So you cannot say, once I know a signaling in a cell, I know them all. It's totally different. It's cell type dependent. It's conditional. Major pathways are second AMP protein kinase A, nitric oxide cGMP protein kinase Q, different effects on endothelin-1. It's an agonist at the glucocorticoid receptor. So that's strange. And we have reworked that, which is we have NMRI data. It really displaces classic steroids like prednisolone or dexamethasone from the binding pocket at the lumen. So it's a high affinity agonist. And the good thing about it is it comes without the notorious side effects of the classic glucocorticoids. So there is no steroid diabetes, there is no disturbed wound healing, there is no downregulation of the glucocorticoid receptor. That's really interesting and plays a huge role in its anti-inflammatory effect. And at least for antifibrosis, there is a heterodimerization of this receptor with the angiotensin type 2 receptor. This angiotensin type 2 receptor is, so to say, a good guy in the angiotensin realm. It is upregulated only in diseased tissue and then acts together with RSFP1. And this is covered here by this icon. Last but not least, there is the Wnt1 pathway, Wnt1 beta-catenin pathway, which plays a huge role for what we really call heart rejuvenation, because it reverts signs of pathological aging. Again, some basic stuff. It's a vasodilator. That's an early work in human systemic arteries, pre-contracted with thromboxane, and this is relaxin. This is substance P as a positive control. It's endothelin dependent. And it's a multi-layer effect. Acutely, there is enos activation, it's nitric oxide dependent. Then over hours, the endothelin type B receptor, that's the vasodilatory receptor in the endothelin system, comes into play. This is intertwined with matrix metalloproteinases and even with growth factors, vascular endothelial growth factor, placental growth factor. And in the long run, it also remodels vessels and leads to angiogenesis, all contributing to a different course of vasodilatation. And along these lines, in our first study, 2005, in severe heart failure but stable patients, Swan-Ganz catheterization, infusion of relaxin over 24 hours, and then monitoring post-infusion for another 24 hours, you see increased stroke volume, unchanged heart rate, meaning there is a huge decrease in afterload, systemic afterload, and a remarkable increase in cardiac index. So very beneficial hemodynamic effects. Relaxin protects from what we call endothelial dysfunction, so the impaired viability of nitric oxide owing to inflammation and oxidative stress. This is of 2012, and we chose a red aortic model. You can see beautiful vasodilatation to acetylcholine in red aortic rings. This is hugely impaired in a dose-dependent fashion by tumor necrosis factor here and even more pronounced here. And this TNF effect is clearly mitigated dose-dependently by relaxin. And this effect rests at least on 4 pillars. As a very general summary here, relaxin counteracts the endothelin upregulation, which causes vasoconstriction via glucocorticoid receptor. It counteracts the massive increase in oxidative stress via upregulation in this model of the SOD1, the cytoplasmic superoxide dismutase. It counteracts arginase activation, which deprives enos of its substrate, L-arginine, again via GR, and via PI3 kinase and AKT. It kind of corrects the enos dysphosphorylation, which also contributes to the endothelial dysfunction. And this is just an example for relaxin being the real GR agonist. So this is HeLa cells, a GR antibody. It shows GR is in the cytosol as expected. Endogenous relaxin is shown by a relaxin antibody. That's the nuclear staining, so DAPI. Upon stimulation with either labeled or unlabeled exogenous relaxin, 1 hour, you can see that the relaxin piggyback on the GR travels into the nucleus. And we have several trials of proof for that, and even MRI data meanwhile. And in contrast, as a negative control, there is no such effect with insulin. So it all stays in the cytoplasm here. So why is that important? So GR is has a huge organ protective potential, and of course a huge anti-inflammatory potential. 2 examples for that. That's a mouse model of liver transplantation, where the entirety of the positive relaxin effect depends on GR. Probably have to talk. Exemplified by a cell culture experiment out of this publication. So hepatocytes are challenged by hydrogen peroxide. They react, of course, with cellular damage. So transaminases go up. They are almost totally reverted by relaxin, but if you knock down the GR, this effect is gone. And this is stimulated cytokine secretion in human macrophages. So up it goes, TNF alpha with endotoxin over different time intervals, and down it goes with either dexamethasone or at a lower dose relaxin. And both effects, dexamethasone, classic steroid, and relaxin, are completely abrogated if a GR antagonist, mifepristone RU486, comes into play. I have already spoken about the Wnt pathway. Actually, we know Wnt from embryology and osteoporosis maybe, but the Wnt pathway is clearing while it is active in adult tissue as well. So the Wnt receptor is the heterodimer here, and there is an antagonist, to this receptor, DKK1, DKOF. And we know that relaxin upregulates Wnt, the Wnt protein, the agonist, and downregulates the antagonist here. And it also, via this pathway, AKT, de-inhibits the tonic inhibition done by GSK3 beta on beta-heptane. So altogether, this results in clear upregulation of this Wnt beta-catenin pathway. This pathway is totally responsible for the electric remodeling upon relaxin. I will talk about this in a minute. And it's partly responsible for relaxin's anti-fibrosis and anti-inflammation. And this is why I think we can call it myocardial rejuvenation. This is the Fisher F344, an established model of personal aging and also an established model of HFpEF. It has some features of HFpEF. And this is two things in one RNA-seq study. It's aging, 9 months, versus 24 months of age. And then it's female versus male, and then relaxin effect. And what you can see is that particularly in the females, all the pathways of inflammation, fibrosis, and oxidative stress are activated just by aging, and all of them are inhibited by relaxin. So it's really a kind of a rejuvenation. Then I want to make one point explicitly. There is not many, but a couple of relaxin analogs out there in development by others. That is very good, but it has to be emphasized. Relaxin analogs are different from native structure, native sequence, non-retarded human relaxin. This is what we synthesize. And I tell you why. It has to do with this complexity of the signaling. I hope I could show you that the GR and the Wnt pathways are of the essence for relaxin effect. And relaxin analogs, they are modified. They modify relaxin in terms of structure or sequence. They couple it to Fc fragments or antibodies just to increase half-lives, or they use those splice agonists, non-peptidergic agonists. And this is one example. This is B7. That's a truncated relaxin. It is fully active regarding anti-fibrosis. It is fully active regarding vascular effects. But look, this is the Wnt-dependent upregulation of the fast sodium channel. This upregulation is prevailingly responsible for the anti-arrhythmia by relaxin. So there's a huge effect of relaxin, but up to 100 nanomolar, there is no such thing with B7. That's one example. And the other one is an example regarding the GR. That is the glucocorticoid receptor expression in mice hepatocytes. And this is ML290. That is the one lead from the NIA high throughput search for non-peptidergic agonists. It's an allosteric binder, a biased agonist. And you see while native structure relaxin upregulates the GR here, and even relaxin that cannot bind RXFP1 is its G protein receptor also upregulates the GR because it's a GR dependent effect. There is no such thing with ML290. There is more examples to it, but I would like to confine it to this. And now we have arrived at HFpEF eventually. So You all know that there is different HFpEF phenotypes in patients in the clinical setting. And this is also the case in preclinical research. And I can safely say that we have shown relaxin effects in all three phenotypes of preclinical HFpEF models. So in the aged rat, so the aging HFpEF, in the ZSF1 obese rat, the cardiometabolic HFpEF, and in the more hypertension-related HFpEF in the angiotensin II model. And I start with this. This is work done by a different group from Florida. Rats are infused angiotensin II for 3 weeks. And once this is full-blown, you start relaxin. And what you can see is down goes the blood pressure, and more importantly, for the clinical setting, down goes the end organ damage. And this is exemplified here by albumin excretion in the urine and by an increase of glomerular sclerosis. And this is the aged rat model. And the aged rat model is similar to human HFpEF in 2 ways. First, it has excessive fibrosis in left atrium, and is highly prone to atrial fibrillation, which plays a major role in the clinical setting as well. And when you treat those rats for, let's say, 2 weeks with vagal or relaxin, then you sacrifice the animals, you put the hearts in a Langdorf apparatus, you load them with stains, so voltage and calcium-sensitive dyes, and then you try to induce AFib by different stimulation protocols, premature pacing or burst pacing, either way around. In all the vehicle-treated animals, you can induce sustained atrial fibrillation, but this does not work in relaxin-treated animals. The worst thing you can induce is transient AFib, be it premature pacing or be it burst pacing. And this can be pinned down to 2 effects. First, there's a huge anti-fibrosis. This is collagen 1, and this is whole collagen here. It is more than half with relaxin. And then there is a huge upregulation of the fast sodium current, which goes along with the expression of the fast sodium channel I already showed you. And a consequence of this is conduction velocity goes up and most likely prevents re-entry circuits. Okay, this is the cardiometabolic model, and this is our preferred HFpEF model because I think it's the best model we have now for HFpEF. So those rats are cross rats between the diabetic fatty rat and the spontaneously hypertensive rat. And if you feed them the high-fat diet, they come at week 8 or 9, and then they have to be fed at least until week 18, sometimes even longer. The model is variable. And you do eco monitoring all the time. Once HFpEF is full blown, you treat it. And then after 2 weeks, you sacrifice the animals. You do this optical mapping again for arrhythmia, and you do immunofluorescence and all sorts of examinations. This just shows you that the model really works. We are doing eco as you are in the clinical setting, only the values, the reference values are different. So there is preserved left ventricular ejection fraction, as in the human setting. Then the major point, there is diastolic dysfunction. E prime goes down, and E to E prime goes remarkably up, and there's even left atrial enlargement, so which is a cornerstone of human HFpEF. And the first slides show you just the effect of the continuous subcutaneous relaxin infusion by outside minipumps. Okay. So I have shown you the course of HFpEF development, and this is 2 weeks treatment with relaxin. Relaxin in green, control in blue, and you see the diastolic dysfunction is actually brought back, reverted to young age levels, as is the left atrial area. And this is a biomarker here. It's hidden now. I can tell you, yeah, you see at least the median. So NT-proANP, which is a good biomarker in that model, it clearly goes up in the natural course of disease, and it goes clearly down with relaxing. And I'm coming back to electrical remodeling and fibrosis. In this model, the ZZ1 rat, fibrosis is very little. So 80 to 90% of this diastolic dysfunction can be attributed to the contractile proteins, hypophosphorylation and stuff like this. So fibrosis plays a little role here, but it goes down a little bit nevertheless with relaxin. And up goes the ring beta-catenin pathways, and up goes the expression of the fast sodium channel. And this is 30%. That's a huge increase for an ion channel. And it is accompanied by current increases, functional increases. And what is also upregulated is connexin 43, that's a gap junction protein. So all this serves to speed up conduction velocity. And these electrical changes here are totally dependent on wind, beta-catenin, and as I said, the IV fibrosis, LV fibrosis is totally dependent on wind. Okay, nice data so far, one could say, but there is a dilemma maybe. I say you should best leave this peptide as is in its natural fashion. But then people say, okay, half-life of relaxin in human circulation is less than 1 hour. So how can you then treat a chronic disease? And it took us some time, but we have come up with a very simple solution that is patented as well. It's just a simple bolus therapy of non-retarded, native structure, native sequence, synthetic human relaxant. Look, this is published. This is left ventricular tissue sections, and they are taken 24 hours after the last sub-Q shot of a 2-week therapy with daily shots of relaxin. And this section is probed with a relaxin antibody. Specificity is confirmed by down titration with exogenous relaxin. And what you can see is at a time where in circulation all the relaxin is gone. We have pharmacokinetics that it's gone after 8 and maximum 10 hours after the sub-Q injection. There is still clear signaling or clear presence in the tissue, and this is what we want. So it seems you have to push the swing at just the right time to keep the effects going. And this is what it's all about. And why is this? And this has to do with this very complex receptor.
Maybe ask a question now.
Yeah.
Just wait.
Just ask.
Okay. And this is for the human or for animal body?
This is our animal model.
And
Yeah.
Did you already test it in the human?
And
Or you're going to?
we are about to collect data in human HFpEF biopsies, and they are brilliant, but it's too early because it's not yet published.
But you don't know how to use it, right? You don't know how to use the human.
It's flat. I can't do this in a minute. We will do a phase 2 in a couple of months. Yeah. So why is that? Because this receptor, this RXFP1, is neither internalized nor desensitized. So that's very different, for instance, from catecholamine receptors or so. And once the peptide is bound, it has a very slow off rate, but only the native peptide, not the relaxin analogs. So there's a lasting stimulation despite short plasma half-life. So there's many genomic effects, as I said, which just need to be triggered from time to time. Okay, and from now on, I'm showing you data with a daily sub-Q injection of non-retarded native structure, human synthetic human relaxin-2 in our HFpEF model. Now this is separated for sex. This is the females. You see this is full-blown HFpEF in those rats. And after 2 weeks of relaxin, the diastolic dysfunction is reverted. That's the natural course of disease. The increase of left atrial area continues in the course of disease. It's reverted with relaxin. And the very same holds good of the males. So there's no sex dependency whatsoever. And I'm continuing now on the electric remodeling. I've shown you all the basic mechanisms. This is just the readouts. And when we are talking AFib and ventricular tachycardia, we are really talking mortality of HFpEF patients, because AFib usually heralds worsening of heart failure in the human setting, point one. And point two, the single most important cause of cardiovascular death in HFpEF phase 3 trials is sudden cardiac death. So if you impact on this, you have a good chance to impact on HFpEF mortality. And this is, again, day-to treatment for 2 weeks, relaxin treatment, and 2 typical examples. You can use ongoing sustained atrial fibrillation or ventricular tachycardia. Here, in this case, by premature beats. There is premature beats, then there's no capture in the relaxin hearts, and then to this bundle action, and then normal rhythm starts. So no induction whatsoever. And in general, you can say you cannot induce sustained AFib in relaxin treated rats, but around about 60% of the vehicle treated develop sustained AFib, even more pronounced in the age group, where 80% are really susceptible to AFib. And the very same applies to incessant ventricular tachycardia. So here comes my summary. Yeah, I think. HFpEF is still the unmet medical need in temporary cardiology. Relaxin's unique receptor and signaling characteristics render it an exceptionally strong drug candidate. A multifaceted syndrome like HFpEF needs a biochronic approach. At least this is what we are convinced of. At preclinical level, the relaxin-2 concept is effective in all 3 phenogroups of HFpEF. Relaxin-2 delivery reverses diastolic dysfunction, arrhythmia susceptibility, inflammation, and excess fibrosis. And the atrial and ventricular antiarrhythmic properties are clinically important for mortality reduction. AFib heralds worsening of HFpEF. Sudden cardiac death poses the most frequent form of cardiovascular death in phase 3 trials in HFpEF. And secondly, with this bolus therapy, signaling can be achieved with periodic pulses of the peptide, irrespective of its short half-life in circulation. This enables excellent therapy control and compliance in highly susceptible patients. We all know the notorious blood pressure lability of HFpEF patients. And very importantly, the entire signaling portfolio of the native peptide is of the essence. This pleiotropic signaling is most likely to trimmed down in relaxin analogs by relaxin modification. And we are currently preparing Source HF, a phase 2A to B clinical trial in HFpEF. I have to acknowledge our partners. So Professor Salama of Pittsburgh, they are doing the animal models for us. Professor Bathgate in Melbourne, they are basic research guys we have partnered with. Immundiagnostic in Germany is doing the ELISAs. In Melbourne, Codwilly is doing the MRI stuff. We have a good cooperation with Nazar Hamdani of Bochum, one of the most renowned HFpEF experts, and together with her, we will be publishing on relaxin's really beautiful effects in human HFpEF biopsies, so which totally confirms this. And I would like to thank all our consultants. Thank you for your attention. Happy to take your questions.